All right, everyone, welcome to October's NICER Monthly Patient Case Conference. We're really excited. Our institutional member, Indiana University, is here today to present a patient case. I'm going to go ahead and give them the floor.
Okay. Well, thank you so much for inviting us for this hour. We're going to present a case that was taken care by rheumatology, infectious disease, hematology, and immunology. I will be one of the presenters. My name is Padem. I'm the immunologist on this team. And then my co-presenter is Rebecca Hetrick. She is with pediatric rheumatology. Okay, so our title is Refractory Cytopenias and Autoinflammation in PSTPIP1 associated myeloid-related proteinuria inflammatory syndrome. We call this as PAMI syndrome. Okay, let's see if I can. All right, we have no disclosures. So today's learning objectives are to essentially present our case, and then we would like to discuss the early presentations of the PSTPIP1 related inflammasome disorders. Then we would like to discuss specifically the biologics that are used for treatment of PAMI syndrome. And finally, we would like to discuss the option of stem cell transplant for PAMI syndrome and a little bit for the other refractory autoinflammatory syndromes as well. So our case presented to the Riley Hospital for children at 4 weeks of age. It was a male infant brought with fevers. At presentation, he was febrile to 100.8. He seemed tired but not lethargic. Parents reported a bit of congestion, however, no other respiratory symptoms, no issues with feeding, urination, stooling, no rashes at that point. So this was essentially a neonate with fever. His past medical history was pretty unremarkable. Born full term via C-section without complications, no NICU stay, normal newborn screen. The prenatal labs and the care was very appropriate, and his size was normal as well. He had no medications, no allergies, received his hepatitis B vaccine at birth. His family history was also very unremarkable. Both parents were in military, very healthy, no family history of blood disorders, cancers, recurrent infections, or autoimmune diseases. He lived with his parents. And the protocol for neonatal fever was started for this patient. Initially had a CBC, which showed pancytopenia. Most remarkably, the platelets were 43K with elevated ANC to 580 with bands and a normal chemistry. The initial infectious workup was essentially negative with RBP and COVID testing being negative. His CRP was elevated to 12.9. His UA was normal, and at that point just had blood and urine cultures pending. The emergency room was deferred LP at that moment due to his low platelets, and he was started on ampicillin and gentamicin for the neonatal fever protocol. At the time of his admission, he continued to be febrile with tachycardic. However, shortly after admission, he started developing some respiratory symptoms to the point of requiring oxygen. He had some retractions, and along with that, he started having feeding problems. So decrease in breastfeeding and ended up on IV fluids. His repeat CBC showed actually a little bit of worsening of the cytopenias around the similar ranges. Still had bands, and at that point, hematology was consulted. They felt like this was most likely infection-related suppression of the bone marrow. The initial 48 hours of cultures were both negative. Oops. So towards the end of the first week, despite being on the ampicillin and gentamicin, he continued to spike fevers, still requiring oxygen, still having issues with feeding, and his head circumference was increasing steadily. His CBCs remained in similar ranges. However, there was a slow decrease in both platelets, and his anemia was worsening. So he had an LP done after a platelet transfusion. On his LP, he had increased protein, decreased glucose, and overall it was felt that he had, bacterial meningitis. However, the initial CSF culture was negative. His meningitis encephalitis panel was negative. His bacterial PCR was negative. He continued treatment for meningitis, especially in the setting of elevated CRP, and the ampicillin was continued. However, the gentamicin was switched to ceftriaxone. For the anticipated prolonged antibiotic course, he had a PICC line placed. His brain MRI did show leptomeningeal enhancement and prominence of the ventricles concerning for hydrocephalus. In early second week of his admission, his feeding issues continued. He was not gaining weight. Sorry, I think the weight was, this was the head circumference, but the weight was not really improving at all. And he continued to develop new symptoms, which was essentially an intermittent rash on the various parts of his body. We did not have a good explanation for this rash. There was a thought that this could be related to the transfusions that he was receiving. However, the rash actually continued to progress. In the meantime, his congestion and cough improved. He came off of oxygen. The hearing exam at that time showed absent responses. So this is later in the second week of his admission. Platelets and anemia very low and continuing to need transfusions. ANC still very low, and essentially his platelets remained below 30K this whole time. His hemoglobin dropped significantly down to 6.5 and below that, and so he has become transfusion dependent at that moment. So hematology was re-involved in this care. However, with the continuing infectious symptoms with the CRPs and fevers, there was the assessment at that time was still that this was an infectious suppression of the bone marrow. There was no evidence of hemolysis and no atypical cells on his smear. So there was a brief couple days where he stopped spiking fevers. However, towards the end of second week, he started spiking fevers again. Still not feeding. His CRP fluctuating, however, mostly remaining high. His head circumference was becoming larger. Infectious disease expanded his workup. They included other viral, fungal, TB testing, which was all negative. The brain MRI remained stable for that second week of admission. And then the vancomycin was added to his treatment for the concern of CLABSI. Because his infectious studies kept coming back negative and his cytopenias were not improving at all, and clinically he was still spiking fevers, infectious diseases reached out to friends and consulted other disciplines, kind of thinking about what else could this be. And given the early age, we didn't feel that the functional immune or inflammatory workup would be the most appropriate next step. We actually went to genetics right away. And I'm so glad we did. And genetics was consulted and a rapid genome was sent, which showed an autoinflammatory syndrome. So at the end of the third week of admission, we had a diagnosis of PSTPIP1 related autoinflammatory disease. We will talk a little bit about these conditions. His variant was labeled as likely pathogenic. However, given his significant cytopenias, persistent fevers, his rash, and lack of response to antibiotics and lack of evidence of an infection, we felt that this genotype was matching very well with his phenotype. So now I would like to hand over the presentation to Dr. Hetrick, and she'll tell us about the PSTIP1 related inflammatory disorders.
All right. I'm Rebecca Hetrick. I am one of the pediatric rheumatologists at Riley. Just finished fellowship, fresh out of fellowship, and I met this patient when I was a third-year fellow. So I'm going to talk a little bit about the PSTPIP1 related autoinflammatory disorders. If you want to go to the next slide. So backing up a little bit to understand where this group of disorders come from, it's important to understand what an inflammasome is and what the pyrine inflammasome is in particular. So an inflammasome is a large multi-protein complex that uses different types of sensor proteins to detect various kinds of infectious threats. In response to detecting one of these threats, an inflammasome will form and it'll activate a proteolytic enzyme of some sort that leads to increased production of a pro-inflammatory cytokine that's critical for immune function. The pyrine inflammasome specifically is a very important part of the innate immune system and leads to increased secretion of IL-1 beta. And upstream changes in the pathways that lead to pyrine inflammasome activity and regulation have been associated with a wide range of autoinflammatory disorders, some of which are fairly well known. Next slide. So normally the PSTPIP1 gene makes a similarly named cytoskeletal protein that's highly expressed in hematopoietic cells. This protein functions to interact with several different proteins in the cytoskeleton and also in the inflammatory process. Under normal circumstances, PSTPIP1 binds to pyrine in a very controlled way. When pyrine is then turned on, it will activate caspase-1, which in turn activates IL-1 beta. In certain PSTPIP1 mutations, this balance is disrupted, and what we think happens is the altered PSTPIP1 protein binds to pyrine too strongly, sort of continuously triggering its on state and resulting in increased secretion of IL-1 beta. Next slide. So the PSTPIP1 related autoinflammatory disorders are a spectrum. The classic and most well-recognized of these, I think, is probably PAPA. PAPA syndrome is pyogenic arthritis, pyoderma gangrenosum, and acne, an autosomal dominant disease that results from a gain-of-function variant in this gene. PAPA typically presents in childhood with sterile arthritis, and patients later go on and develop severe acne and skin ulcerations during adolescence. PASH is another PSTPIP1 related autoinflammatory disorder. It stands for pyoderma gangrenosum, acne, and suppurative hidradenitis. And then there's even what I assume is called PAPASH, or I'm not sure, but and PAPASH is a distinct PSTPIP1 variant that leads to an overlap syndrome almost between PAPA and PAPASH, where you have features of both. PAMI syndrome is really distinct from these other three diseases. And I think the phenotype is generally more severe than PAPA or PASH syndrome. So PAMI is characterized by cytopenias, elevated zinc levels, elevated systemic inflammation, prominent skin inflammation, prominent arthritis. Patients generally have splenomegaly and failure to thrive. Hallmarks of the disease are elevated zinc levels and elevated calprotectin levels. Most affected patients have anemia and thrombocytopenia. Next slide. And neutropenia and splenomegaly are also two unique features that help distinguish PAMI syndrome from PAPA or PASH syndrome. For our patient, his zinc level already at 4 weeks of age was elevated 2 times the upper limit of normal. Next slide. So we have really limited data in PAMI syndrome. PAMI is rare, with only really case reports and case series. There was a systematic review published in 2023 that aggregated 43 cases of patients with PAMI syndrome, although those patients had two very well-described variants of the disease. Next slide. So, digging into the systematic review, I think it can give us sort of a flavor of what the classic phenotype looks like. In this review, about half of the patients were male and female, or half were female, half were male. There was no ethnic or clustering within the case series that was put together. And information about consanguinity was not available for most of the cases. The median age at onset of the disease was 3 years of age, and 40% of patients had their first symptoms appear before their first birthday. 80% of patients had their first symptom appear before 6 years of age, and the age at diagnosis varied very widely. Next slide. So patients tend to present with early onset systemic inflammation. The majority of patients in the systematic review had what were called sort of serious manifestations, characterized by severe cytopenias, prominent skin rash, prominent arthritis, and multi-organ involvement in most cases. Most had growth failure, and symptoms tend to appear and then accumulate over a period of years. About 12% of cases had a more mild phenotype with just mild cytopenias, mild skin, or mild joint disease. And interestingly, in the case series, they found that there was phenotypic heterogeneity even among family members who had the same variant. So of patients, about 72% had joint involvement, 74% had skin involvement, 70% had splenomegaly, so most had splenomegaly. Hepatomegaly was a little less frequent, about half had hepatomegaly. Over half had failure to thrive, and about half of patients had recurrent fevers. Less frequent symptoms were things like lymphadenopathy, GI manifestations. Developmental delay was only found in about 11% of patients. There was one case in this systematic review of severe pulmonary hypertension. 16% of patients experienced recurrent infections. I'm sorry, not 16%, 16 of the 43, so about 40% of patients experienced recurrent infections. And 9% of patients in this systematic review had experienced macrophage activation syndrome as a complication. Next slide. All patients, so 100% of patients had some hematologic involvement. All had mild to severe anemia. 98% had neutropenia. Thrombocytopenia was present in about 40% of cases. All patients who were tested had elevated sed-rate CRP or other inflammatory markers. And all who had their serum zinc levels or calprotectin levels checked were also elevated. They did not do because this is just a systematic review of case series and case reports, they didn't consistently do cytokine profiling or bone marrow biopsies across patients, but of the patients who had cytokine profiles, IL-18 levels, which is an important, which is often elevated in disorders of the pyrene inflammasome, was elevated in all of those who were tested, as were interleukin-1 beta. Bone marrow biopsy showed hypocellularity in a few patients, hypocellularity cellularity in most, hypercellularity in a few, and then different degrees of fibrosis and dysplasia. And then the majority of patients had de novo variants. Of those who had genetic testing of their parents, 76% were de novo. Next slide. So treatment of PAMI, and you can go to the next slide, is highly variable and it is not particularly effective. PAMI has been treated with a wide variety of immunomodulators. I found this slide to be somewhat misleading because while it shows you response to individual immunomodulators, it does not capture sort of the complexity of regimens that patients were on, or when patients were on combined regimens. So for example, this case in this systematic review, 9 out of 11 patients who were on cyclosporin appeared to respond to cyclosporin. But those patients were also all on chronic glucocorticoids as well. So patients who were on IL-1 blockade were more often on IL-1 monotherapy than some of the other regimens. So, and I'll talk a little bit about, next I'll talk about our patient in particular and what treatments we've tried so far. In 2020, there was, sorry, I was just going to say, in 2020, there was a group that did a case series of 5 patients who were transplanted with, who had stem cell transplant with PAMI syndrome. In those 5 patients, the indication in 4 of them was treatment failure, and the 5th was development of a myelodysplastic syndrome. Initial transplant was successful in 4 of the 5. The 5th patient required a second transplant, but at follow-up, all patients appeared to have adequate recovery and were free of PAMI syndromes, of PAMI syndrome symptoms. So next slide. So these are some photos from our case. Our patient, as he grew older, also appeared to acquire sort of additional symptoms and manifestations of PAMI syndrome. So he has severe pancytopenia. He's on daily filgrastim injections. He receives platelets and red blood cell transfusions about every 10 days to 2 weeks on average. He has a standing appointment with our infusion center where he goes in once a week to have a CBC checked, and generally requires transfusion. He has severe inflammatory arthritis. You don't have to be a rheumatologist in that top picture in the right to see the boggy swelling of his knee, or even the soft tissue of his feet. He has inflammatory skin rashes. He's also often covered in petechiae because his platelets live somewhere in the 10s to 15s. But mom has gotten really good at telling the two apart because one is sort of more of like a pustular acne-like rash, and the other is true petechiae. He has splenomegaly. He is failure to thrive. He is dependent on an NG tube, and he has had some growth now that he's been placed on an NG tube, but he is still certainly smaller than he should be, both in terms of weight and length. He had a prior episode of MAS after a viral infection when he was 4.5 months of age. And then he certainly has elevated systemic inflammation. Next slide. So shortly after we got his diagnosis, he was started on anakinra, so IL-1 blockade with anakinra at 2 milligrams per kilogram per day. He, over time, has been bumped up to 8 milligrams per kilogram per day. I think the only real success that we've had with anakinra is that when he did have his episode of MAS. He went into that episode on 2 milligrams per kilogram per day. We were able to control his MAS by going up on his anakinra without having to add steroids. But really, kind of outside of that episode, anakinra has not been particularly helpful at controlling arthritis, rashes. It has helped recurrent fevers also, I'll give it that. But it has not at all helped with cytopenias or any of the hematologic manifestations. So with that, at 5 months of age, we started ruxolitinib or Jakafi, which is a Janus kinase inhibitor that is preferential for JAK1 and JAK2 at 1 milligram per kilogram per day. In terms of his sort of lab markers of inflammation, Jakafi did not do much to change to really move the needle. CRP, ceterate, ferritin, and IL-18 are still very elevated. But parents noticed a big difference after we placed him on Jakafi. In particular, they said his inflammatory rash became far less frequent. He was far less irritable, and he was more alert. And he had no further episodes of MAS despite having a couple of viral infections after he went on the Jakafi. So not a complete failure, but again, he's still transfusion dependent. He still has horrible inflammatory arthritis. He has joint contractures in the ankles and knees now. And so more recently, he was started on high-dose oral steroids now that we felt like a transplant is within sight for him. There would be an end goal to starting those steroids. So he's been started on steroids for the arthritis and as well as trying to achieve better systemic control of his systemic inflammation prior to transplant.
Okay, so now that we talked about the case course and the biologicals that have been used and trialed for this case, I would like to cover the stem cell transplant as a potential option for refractory cases in PSTPIP1 related disorders. Let's see. Okay, so this was one of the initial reports. I think we've already covered this, where the inflammatory response to biologics have been okay, but the cytopenias and lymphoproliferation was also noted to be non-responsive to biologics, especially the IL-1 blockage, even in the initial series described with PAMI syndrome. So with about 10 years ago, when the disease was nearly first started to be reported, there was a case series of 15 patients where they could not find any consistent effective therapy, and the best response was with IL-1 blockage, but even with that, 1/3 of patients were completely unresponsive. So having these patients who are transfusion dependent, some having lymphoproliferative complications, I think transplant was kind of brought up as an option. And really the only good report that we have is from 2021, where the group from Russia have done transplants for 5 patients. I know Rebecca kind of mentioned that, but I would like to go over this one more time just because it's the main report that we have in hand. Their indication was kind of the similar as our patient, where they've tried either immunosuppression or anti-cytokine therapies, and the symptoms, particularly the cytopenias, were not responding. So with that, for the resistant cases, 5 patients underwent allogenic hematopoietic stem cell transplant. The 4 patients diagnosed, the indication for 4 patients was the lack of disease control, and 1 patient had developed myelodysplastic syndrome. The patients in this report were actually much older than our patient, and the median age for the patients at the time of transplant was 8.1 years. Most received myeloablative conditioning, and 1 received a reduced intensity. All 5 patients engrafted. I don't think we will need to go into the detail of these, but the complications were actually in 2 patients, the major complications. Other, expected infectious complications, including CMV viremia, occurred. However, one patient specifically developed HLH at day 13, which led to graft rejection. And over the next 5 months, the patient actually required a second stem cell transplant. Another patient developed a systemic inflammatory syndrome with psoriasis and mitral and aortic valve regurgitation. And I believe this was a little bit later, I think after the first year of transplant, and they were able to control this inflammatory response with prednisone and tacrolimus and adalimumab. There were some other, again, infectious complications that occurred during transplant. However, there were no other non-infectious episodes or severe acute or chronic GVHD in these 5 patients. At the time of the report, which was back in 2021, the median follow-up was 2.2 years. They were pretty much all predominant or complete donor chimerism. They all had good immune recovery, and they did not have PAMI symptoms. They did not have any serious conditioning-associated toxicity. And when our transplant team communicated with the authors in 2025, these 5 patients were still doing well overall. So this was specifically for PAMI syndrome, and I kind of wanted to give an idea about the transplant for other autoinflammatory disorders, because this is not, even though we use stem cell transplant commonly for immune errors of immunity, autoinflammatory syndromes are kind of an exception to this. There are a couple of reasons why we don't do transplants commonly for this group. One, we have other medications to use. The biologics work for most of these syndromes. And 2, there's a bit of more complications to the transplant in ongoing inflammatory responses. So this is the list of autoinflammatory syndromes where transplants were trialed. For most of these diseases, it's limited to a couple patients, really. I believe the deficiency of adenosine deaminase 2, maybe they have the most number of patients who have been trialed, but I would like to focus more on the PAMI, FMF, and the mevalonate kinase deficiencies, just because mechanistically they're a little bit closer to each other. And unfortunately, there are not that many patients who had diseases of pyrene inflammasome and ended up having transplants. So when we looked up, it's actually surprising that PAMI syndrome, as rare as it is, had the more numbers of transplants than FMF, for example. And again, there was one case who was a 7-year-old female with FMF and had congenital dyserythropoietic anemia. And the real reason for the transplant was the frequent blood transfusions for the anemia. So it was not necessarily for FMF. However, after the transplant, the patient actually had no need for transfusions, and the FMF-related symptoms have resolved. So I think for FMF, even though it's the most common autoinflammatory syndrome, just because how effective colchicine and IL-1 blockage is, I don't think that we will be referring patients with FMF for a transplant very often, unless they have a special situations like this patient. Similar for mevalonate kinase deficiency. I mean, there were only 9 patients, and the indication was very much similar to PAMI. If they were refractory to biological agents in terms of their autoinflammation, then the transplant was considered. So considering this group, they're probably on the more sicker side of the patient population. So their outcomes were not as encouraging as we had for PAMI, even though 8 patients achieved remission, 2 actually ended up requiring another transplant, and 4 developed GVHD, and unfortunately 2 patients passed away. So whether this is because they had more patients and they have more different variety of outcomes, or maybe the mevalonate kinase deficiency is truly not the best fit for transplant. It's unclear, but you can also see that still patients, most improved and achieved remission. So that's encouraging. Again, the limitations are pretty established by now. The main limitation for the transplant in autoinflammatory diseases is that there's cytokine production in non-hematopoietic tissues. So we might replace the bone marrow. However, throughout that process, throughout the transplant process, there might be the cytokine production going on in the rest of the body. So that's a major problem. Then we know that for some of these conditions, there's a gain of function of somatic mosaicism. So it comes to the same point, but there might be a bit more inflammatory response that we see from the somatic tissues rather than just looking at the bone marrow or just looking at the genetics does not really give us a good idea of how severe the autoinflammation is. And then the third is that throughout this transplant process, there will be ongoing autoinflammation. So I think that's another limitation, and it just makes the transplant course and the conditioning so much more complicated. And there's a good example to this, where there was a case reported, a patient who received a stem cell transplant for their mevalonic aciduria, actually had a full donor chimerism, but after 18 months of transplantation, his urine mevalonate levels returned to the pre-transplant ranges. So despite this full chimerism, he essentially continued to have his disease in the same frequency or same severity and ended up on IL-1 blockage regardless. And so whether this is specific to mevalonic aciduria or this particular variant that this patient has, or does this apply to all autoinflammatory syndromes, this remains unknown, but there's at least one case of full donor chimerism, no significant complications, but the disease was actually continuing with the same severity. So this is definitely a consideration. So as a conclusion, the stem cell transplant can be a cure for cytopenia and severe autoinflammation in PAMI syndrome. And because of the reasons that we just talked about, we would only save this option for patients with poor disease control, who's been on immunosuppressives and anti-cytokine therapy, which unfortunately our patient is at that point. So now that he's on IL-1 blockage and JAK inhibition, and the joint symptoms and the growth being severely problematic, and having the cytopenias that are not improving at all, is a main barrier for us. So we're considering, we're lucky to have a transplant team here, and we're lucky that he has some good matches. So we're hoping to bridge him to transplant with the steroids that was mentioned, and then hoping for a good outcome, just like these other 5 patients did. Okay, so at this time we can take any questions if you have them, but we would like to thank you as the High team, which is the multidisciplinary clinic at Riley. It's rheumatology, infectious disease, hematology, and immunology. And if there are any questions or comments, please let us know.
Thank you. There is a question in the chat. Is PSTPIP1 expressed in any other cells other than hematopoietic?
Great question. I did not see an
It is expressed in
Okay,
other types
yeah.
of cells, but it is highly expressed in hematopoietic cells. Beyond that, I don't know much detail.
Yeah, I mean, I think it's interesting that this is one of these autoinflammatory syndromes that leads to persistent cytopenia, because most autoinflammatory syndromes would not have cytopenias, but this one seems to be a bit more expressed in hematopoietic stem cells.
The question in the chat was IL-18 high, and consequently, was there a lot of T helper 1 development and gamma driven? Was CXCL9 high? Yeah, so his IL-18 level has been consistently high. He typically ranges between 20,000 and 22,000 for his IL-18 level. We did capture it when he was in MAS. He went up to 75,000. His IL-18 level, we have not made a dent in, even with anakinra at higher doses or with the JAK inhibition. His CXCL9 level is high as well. But not as dramatically elevated as his IL-18 level.
Hey, this is Manish from UCLA. Great presentation. The reason I ask is because if IL-18 is driving a lot of type 1 immunity and gamma is driving a lot of the disease, then IL-1 blockade isn't going to help much. Of course, this is an inflammasomopathy and you need to block IL-1, but if a lot of the disease is actually being uncovered because of gamma, then upadacitinib might be a better choice than Rux, baricitinib, or tofacitinib, because you can block JAK1 specifically. You can go higher. Not that it's a hell of a lot safer than the other pan-JAKs, but it's something you can try. I have some STAT1 gain-of-function patients that do better with upadacitinib than with the pan-JAKs. And again, this is all guided by CXCL9 because it's such an easy biomarker for gamma-driven pathology. And it gives you a chance to block something else that is targeted.
His CXCL9 is not nearly as dramatically elevated as his IL-18.
No, it won't be. It's downstream. But yeah, the other thing is there are 3 IL-18 blockers in development. Have you reached out to the manufacturers? You can get compassionate use for them?
We have not.
Yeah. But I think for any of the major inflammasomopathies, blocking one is never enough. Like, blocking 1 and 18 is needed. So something to think about there. There's also a gasdermin blocker. IL-1 and IL-18 are both secreted from cells, and they require secretion through gasdermin D. So, of course, blocking the cytokine itself is lovely when you can get away with it, but blocking the secretion of the cytokine basically cuts off the faucet at the tap. And so, using a gasdermin D inhibitor in this kind of case might be a way of getting both IL-1 and IL-18 suppressed. These are all off-label use, of course, but this is what you have to do for these patients, right? Just throwing some ideas out there. We take care of a lot of inflammasomopathies, and it's often really challenging to control all the downstream pathology.
There was another question, which was, are there common infectious etiologies to trigger persistent inflammation, persistent cytopenias in these patients? Honestly, in our patient, aside from going into MAS, he has not had much. Once he got on anakinra, he's not had much of a sort of inflammatory roller coaster in response to infections. He's done pretty well on JAK inhibitor and IL-1 in response to his viral illnesses. And as far as we can tell, the cytopenias, nothing has moved the mark on the cytopenias. I don't know, Nur, if you have a different opinion, but I mean, he has been getting platelets weekly to every other week, and PRBCs about every other week since he was hospitalized at 4 weeks of age.
Yeah, I agree. Even, I don't know, Manish, do you think that IL-18 blockage will help with the cytopenias? I don't know. I think there was a point that we got his, I know the IL-18 level did not really change, but the soluble IL-2 and CXCL9 were better at some point, like when he initially started, I think, ruxolitinib, but nothing really helped with the cytopenias, even during that brief period of time when he seemed to be improving in terms of the markers. Cytopenias were as severe as it was before. So that was really discouraging in terms of using the biologics and trying more and more, and knowing that he was actively getting worse. So we weren't sure how much time we had until his whole body was swollen. And so that I think that was one of the limitations with biologics. Like, how many do we try, and how many complications are okay to just kind of wait through until we get to transplant, especially if there is this good transplant outcome, even though we recognize that it's in 5 patients. So, but that was one of the limitations for trying to use any more biologics. In terms of the infections, I'm not aware of a common infectious reason to trigger persistent inflammation beyond the regular viral illnesses. That he's never had things like EBVs and CMVs and other herpes viruses. Never had that kind of a severe illness. And even at his initial presentation with the where we had the concern about meningitis and encephalitis, everything was completely negative. I did not see any reports of a common infectious reason to trigger inflammation.
Thank you.
I would just say the graft rejection that accompanies a lot of these primary graft rejection with a lot of these autoinflammatory transplants. I think the lessons learned from STAT1 gain of function of keeping these patients on JAK inhibitors and even using emapalumab prior to transplant was a major discovery, and it allowed like transplants to start succeeding in STAT1 gain of function and in Icaros and other ones where it's just forget about it otherwise. The same thing could be done here. I went back and looked at that 2021 JACI article. I didn't see that they used JAK inhibitors prior to transplant, or emapalumab. So those were almost doomed to fail. And that was in an era when people didn't know any better. So transplants nowadays, especially done with inflammatory blockade prior to transplant, I think probably have a much better chance of getting primary graft success. I would definitely tee up your patient for transplant. It's a very good strategy. I was just trying to throw out some other ideas in case there's no HLA match. You're not going to do a haplo. You might have to come up with other strategies. So I was thinking about some other things for you.
Yes, thank you so much. This is actually a great discussion, because this was a discussion we've had for months. What else can we do? What is more sustainable? What is not? And then when he ended up having, I mean, Miriam is in this meeting, but I think he has 3 full matches.
Great.
So when that happened,
Yeah.
and I think the plan is to continue the JAK inhibition, right, Miriam, throughout the transplant?
Yeah, he's got a lot of potential fully matched unrelated donors, which is great. The plan is to slowly kind of overlap weaning his current immune suppressive therapy with the start and finish of his conditioning regimen. So currently we're planning to stop his anakinra at the start of conditioning. He will get 3 days of ATG, so we'll wean his steroids over that period of time fairly quickly. Consider him adrenal suppressed for the rest of transplant. And then we will most likely wean the Jakafi off by, day 0. I'm also planning to give 1 dose of Toci on day -1. I was thinking about Gamifant, but like Rebecca said, I mean, at diagnosis, his CXCL9 was in around 2,000. We did capture it as well during his MAS, which went up to 130,000, but most recently it's actually 647. His interferon gamma has never really been elevated except during his, MAS period. Otherwise, it's always, been actually normal. So that is my current plan with transplant. I'll be using like an ATG trio flu regimen for him.
Yeah, Miriam, I don't know if you know Joe Oved at MSK, and now I think he's moving to Columbia, but he's done a bunch of these. I don't know if talking to him might help too, but it sounds like you're right. If the CXCL9 isn't that high, it's probably not worth giving him a emapalumab.
And jumping through all the major hoops, not to mention, but I haven't talked to Joe Oved, but that might be good. If you can send me his contact, that'd be awesome.
Right, any other questions, ideas? Okay. I'm going to stop sharing then.
Thank you all so much for attending today. I will be sending out the CME credit link to claim if you'd like to claim CME for today's session. And we are looking for a presenter for November. So if anyone would like to present a patient case, please reach out to me, Evelyn, and I'd be happy to get you on the books. Thank you both again for presenting today. Thank you, Indiana University, and we hope everyone has a really great day.
Thank you. Bye-bye.